Can everyone hear me? People on Zoom, can you hear me? Hello? Sorry. Can people on Zoom hear me?
Yeah, we can hear you.
Okay, great. Cool. Should we start or wait for a few more? We can start? All right. Good afternoon, everyone. I'm Hafsa, for those of you I haven't met, and I'm going to be giving the critical care lecture today, and I wanted to start with a case scenario. So let's say, this is a hypothetical case scenario. Dr. Shakaroon is holding the triage phone today. She's on call. So let's say, you're holding the triage phone. It's Friday. It's at 4:30. You just came back from lecture. You have 2 central lines to do, and then there's an A line that you need to supervise, and getting calls from the ER and calls from, the GPU, B6. Your other fellows in the MICU also want to sign out, so they're calling you. And then you get a call from ATMO, and our favorite thing. And it's about a patient who Dr. Desai had gotten report on earlier that week. So you shuffle through your cards and you find the card for the patient. Thankfully, the handwriting is not that horrible, so you don't have to squint reading it. And it's a, pretty typical transfer. It's a 66-year-old female with a history of cirrhosis, admitted to some hospital up north, who needed to be transferred for liver transplant eval. Had a very long hospital stay, 67 days. Initially, had decompensated cirrhosis, sepsis, hepatorenal, started dialysis, a GI bleed. Seemed like, the outside hospital did a great job controlling everything, and now she's stable, she's trached, she's pegged. They think that she can come. As always, we don't have that many beds, so we just add the card to the deck and wait on a bed to open. So you get a call from ATMO, and they are saying that the physician who's taking care of the patient wants to talk to you because there's some updates. So you get on the phone, and it's a resident who's, breathless, giving you updates about the patient. She was doing okay. Yesterday started to require a little bit of levo. We did a little bit of a workup. We think she's septic. We're not sure. So you start asking her questions. Doesn't seem hemorrhagic shock because hemoglobin is just a little down, not that coagulopathic. White count is up to 23. They have the patient on escalating doses of levo, now starting vaso, already got the sepsis bolus and more, already started broad spectrum antibiotics and antifungals, but the patient's not getting better. You ask the resident, okay, where do you think the source is? Why is the patient not getting better? They're not sure. Radiology read the x-ray as maybe fluid overload, maybe an opacity. They're not sure. They did do an ultrasound. They were worried about acalcular cholecystitis. Nothing there, just some sludge. Then you ask about skin exam. Resident's not very sure. He pulls up a note from the nurses from the day before. He says that there's a sacral, maybe stage 2 or 3 DQ, but it looks like it's clean. It's not infected. Patient's on the same bench requirements, but now getting more and more acidotic with a lactate of 6.4. So, she's getting really sick. So you get off the phone, get on the phone with charge nurse and, get her a bed. Thankfully, pod 2 is opening a bed. So we accept the patient. She gets flown in, comes in right at the time of shift change. So you and the residents are, right on top of it, going through all the different records, putting in all the prelim orders, and you go in to see the patient as they're getting ready to roll her from the stretcher to the bed, and you see this. Sorry for that picture. What do you guys think she has? This is her sacral DQ that looked uninfected yesterday, per the nursing note. Someone take a guess? You see a little bit of discoloration over here, right? Some bruising. And then it's an open wound. It's probably not very, very clear on your guys' screen. Yeah, but probably even more.
Is it tracking?
It is tracking, yeah. But more so, you have someone who is on 2 pressors now and is very septic, not improving. So, yep, so neck fash, right? Which brings me to the topic that we're going to be discussing today. which is severe necrotizing skin and soft tissue infections. I would like to thank Dr. Higop for helping me review this presentation. And by the way, that whole case scenario was just made up. It was not a real patient. I did put it up there because it touches on some significant points that I will talk about throughout the presentation. I have no disclosures. I do want to say I have a few graphic pictures there. I hope that you guys enjoy your pizza. This is an overview of the things that I'm going to be talking about. We're going to be talking about the definition of necrotizing soft tissue infections, classification and microbiology, epidemiology, the different risk factors, clinical presentation, diagnosis, management, and outcomes. So the first part of my presentation talks about definition and classification. And the literature has a lot of different definitions, but in general, necrotizing soft tissue infections, or NSTIs, represent a rare group of severe and heterogeneous infections. These are usually characterized by key things, and these things are fulminant disease with tissue destruction, signs of systemic toxicity, organ failure, and high mortality. The way it presents to us as intensivists is usually in sepsis or septic shock. It's very important that we recognize necrotizing skin and soft tissue infections from the not as severe, non-necrotizing soft tissue infections, because these will not only need medical therapy, but also urgent and sometimes emergent surgical intervention. There's other classifications out there based on microbiology and anatomical involvement that we'll talk about. But before we do so, just a little bit of nomenclature. Necrotizing fasciitis, the one thing that we're all very aware of. What it means is it's an infection of the soft tissue, resulting in destruction of the fascia of the muscle, as the name implies, fasciitis, as well as the overlying subcutaneous fat. Usually spreads to involve the fascia and around the facial plane, but not the muscles themselves. And that's inherently related to the tissue characteristics. The muscle fascia doesn't have that well of a vascular blood supply, as well. The muscles have excellent blood supply and are able to clear out the infection a lot faster. A very common example of this is Fournier's gangrene. And as a medical student back home, I remember seeing a case of Fournier's gangrene, and that image is engraved in my head. The patient never made it. And having said that, I wanted you guys to have some pictures up there. So we've got Fournier's gangrene and necrotizing fasciitis involving the lower extremity. Another term that we don't hear very oftenly is necrotizing myositis. And the reason we don't hear this is because this is a very rare form of necrotizing soft tissue infection. And as the name implies, it involves infection of the skeletal muscle. I think when I was doing my literature review, I read that there was a report out there that looked at the incidence of the number of times necrotizing myositis was used as a diagnosis from the 1900s into the 1980s. And it was somewhere around 6 cases. So 6 cases over the course of 80 years, usually preceded by a skin abrasion, blunt trauma, or heavy exercise. There is a subset which is related to clostridial infections that can cause necrotizing myositis. Lastly, necrotizing cellulitis, again, as the name implies, it's infection that is only involving the skin, sparing the fascia and the deep muscle, most commonly caused by group A streptococcus. And this is actually, this could be present when you have someone who has streptococcal toxic shock syndrome. And this is where you would classically find crepitus in the skin. Microbiological classification. So we classify severe necrotizing soft tissue infections into 2 categories, type 1 and type 2, based on microbiology. Type 1 is the more common polymicrobial, usually caused by anaerobic, aerobic, and facultative anaerobic bacteria, all acting synergistically. Your less common type 2 infections is monomicrobial, caused by one microorganism. The most common is group A streptococci, followed by beta hemolytic streptococci, less commonly staph and MRSA, more commonly gram negatives if you have someone who's immunocompromised, And then, like we said, NSTIs caused by group A streptococcus can be present in up to 50% of the cases of streptococcal toxic shock syndrome and are actually included in the definition and criteria of toxic shock syndrome. This was a quote that I thought was interesting, basically saying that we shouldn't bother ourselves that much with microbiological or anatomical classification, because when we see these patients, the most important thing is to just identify topographical involvement. You need to act very fast, which is going to be the theme of this presentation: early recognition and early treatment. So next, we're going to talk about epidemiology and risk factors, and I've derived most of the data from this extensive literature review that was published in 2020 in the Journal of Clinical Microbiology and Infection by the title of Necrotizing Skin and Soft Tissue Infections in the Intensive Care Unit. They did an extensive Medline and Cochrane literature review and gave us some nice data that I'd like to share with you guys. They looked at many studies and eventually narrowed it down to 222. There were no case reports that were examined. The epidemiology that they reported, which was pretty much similar to the epidemiology from other studies, was interesting, I thought. So population incidence of necrotizing soft tissue infections is 4 per 100,000, with only 0.2% of ICU admissions being accounted to the diagnosis in the UK, and only 1.2% of critically ill patients admitted with sepsis in Netherlands. So the incidence and the prevalence is not very high, but when we do see this, when we do see a case of necrotizing soft tissue infections, patients are usually really sick. So a quarter to a half of our patients, 25 to 50%, will develop septic shock and or require mechanical ventilation. Up to a third, 33%, will develop acute renal failure. Their ICU median length of stay is anywhere between 5 to 12 days, and the mortality rate's pretty high, 20 to 30%. So even though, again, low incidence, low prevalence, when it does happen, carries a very high mortality rate, pretty significant morbidity on the patient, and likely needs a lot of resource utilization in terms of healthcare systems. Average age of onset of the disease was anywhere between 50 to 60 years, and there was a slight male predominance. And interestingly, the authors reported that 4 to 12% of the patients actually had recurrent NSTI, so it was a second or third episode. Some of the risk factors, and before we talk about the risk factors, they described the most common location of an NSTI, limb or extremity being more common. Lower being more common than upper, 70% of the cases. Perineal or genital, which is our Fournier's gangrene, accounting for the second most common, which is 15%. Cervical, thoracoabdominal, and orbital occurring very less commonly, 5%, less than 5% each. The portal of entry for the infection was different based on the anatomical or topographical involvement. In lower and upper extremities, it was usually related to trauma, chronic leg ulcer, burns, insect bites, IV drug abuse. In perineal or genital, it was usually digestive or urinary and genital, and then other causes for cervical, thoracoabdominal, and orbital. The main risk factors and the main risk factors that you'll see amongst all the different locations is immunosuppression, diabetes, and obesity. Risk factors for lower extremity also included, chronic lower limb ischemia and male gender and age above 60. Trauma for orbital. So now we're going to come to clinical presentation, and I think this is probably the most important part of my presentation. So when should we suspect an NSTI? And I put up that clinical scenario that I made up initially because there's some points that we can take out of it, or we can learn from it. When would you think that this is not just a simple, cellulitis or an abscess? Whenever you have a cutaneous infection showing either signs of local or systemic toxicity, and bear in mind, it's very difficult to distinguish necrotizing from non-necrotizing because they all present the same way with the same symptoms, with the same signs, the erythema, the edema, and the pain. And I don't know about you guys, but at least I used to think that, bruising, bullae, and crepitus would be present way more often in someone who has a necrotizing infection. But interestingly, the infect study group found that bruising was present in only 51% of the cases, bullae in 27%, and crepitus in only 14%. So we shouldn't just rely on these clinical findings to say that the patient has necrotizing infection as opposed to a non-necrotizing infection. If we do that, we miss up to 70% of the cases. And I'll go over the data that was from a study that found that. Another thing that you want to bear in mind is if you have someone who is in sepsis or septic shock, or they're not improving with antibiotics, or they're requiring opioids, or if they're having pain that's extending beyond the cutaneous, macroscopic cutaneous exam, then that's when you would suspect that they would have, a developing or an evolving necrotizing soft tissue infection. And this is the study that found, the study by the title of Early Diagnosis of Necrotizing Fasciitis, that found that if you relied on clinical cutaneous manifestations, 71% of the patients were initially misdiagnosed. And that's a scary number because these patients are usually sick with very high mortality rates. The table up there shows the signs and symptoms of the early versus late and very late disease. Early, like I said, it's similar to non-necrotizing, simple cellulitis or soft skin and soft tissue infections, usually fever, pain, erythema, warmth, tenderness, and induration. Later during the course, you may have purple discoloration, hemorrhagic bullae, crepitus, you get into sepsis, hypotension, organ failure. And then very late when you have frank necrosis, overt pus, and loss of sensation. So then the diagnosis, how do we make the diagnosis? The gold standard is actually surgery. You take the patient for surgery. The surgeon will tell you that I found swollen, dull gray tissue with brownish exudate with or without necrosis. Other than that, we don't really have a diagnostic tool to use. We have supporting data, but surgery is the gold standard. Surgery is really important, not only to make the diagnosis and to manage the patient, but also to get microbiological testing. So you need tissue to send it for microbiology, so you can guide your antibiotic therapy. You should have a very high level of suspicion. So in a patient, like the clinical scenario that we talked about, let's say that the day prior, she, did really have a sacral ulcer that didn't look that impressive, but she's septic on two pressors, not responding to antibiotics, and you don't have any other source to blame sepsis on. That's a case where you would have high index of suspicion and probably take her for surgery, not wait until, she presents with overt neck fash with bullae and hemorrhagic bullae and whatnot. So like we said, if clinical suspicion is high or the patient is septic, you take them for surgical exploration to confirm the diagnosis. There is a risk indicator that's been proposed in the literature. It's called the Laboratory Risk Indicator for Necrotizing Fasciitis. It usually relies on a number of lab tests, including CRP, white count, hemoglobin, sodium, creatinine, and glucose. The authors who came up with the score found that a score of more than 6 was associated with a positive predictive value of 57 to 92, a negative predictive value of 86 to 96. And it was patients who scored above 6 on this risk indicator actually had worse outcomes. So then why don't we use it? In all honesty, I hadn't known about it before I did my literature review. And the reason we don't use it is because we have not been able to reciprocate that data. So we haven't been able to validate it. And many researchers found that it actually had very poor sensitivity and should not be used to rule out an NSTI, especially since this disease can have pretty high mortality rates. So because of that limitations, where it's not very widely implemented, you can find other lab markers that will be elevated, CPK, especially since there's usually some muscle damage, procalcitonin and lactate, but none of these have any diagnostic utility in NSTIs. They're usually just elevated because the patient's also septic. Imaging. Generally, imaging has pretty low yield and more importantly, should never delay surgical intervention, especially if the patient is sick enough, especially if the patient's in our ICU, septic, on the vent, having end organ damage. The different sensitivities, standard x-rays really don't add that much for diagnostic utility. They're positive and they show gas in only 10 to 25% of the cases. So if they're negative, that doesn't mean that the patient doesn't have an NSTI. If they're positive, yeah, that's good, you know, just to confirm the diagnosis. But if they're negative, I would take that with a grain of salt. What about CT scans? You know, they will show some findings, but you won't be able to differentiate that from non-necrotizing infections because the findings will be pretty much the same. They'll just show some soft tissue swelling. MRI is the most sensitive and specific. It usually shows thickening of the deep fascia and intense signal uptake on T2 images and contrast enhanced T1 images. However, it's timely, should never be done in patients who are, you know, sick or patients who are undergoing surgery. The last thing you want to do is send someone down for an MRI for 2 or 3 hours when they're septic and they should actually be in the OR. You would consider images in cervical, thoracoabdominal, or perineal NSTI since you want to know the port of entry, or the surgeon will want to know the port of entry before taking them for surgery to plan for the procedure. And this was a case of a patient who had presented with Fournier's gangrene. You can see here he has a stage 4 sacral decube, and then there's some necrotic tissue around the scrotum. There's gas with tissue destruction on the CT. And then this was post-op. He had a right orchidectomy and he was trained. Management and outcomes. Patient transfer. So remember our patient, you know, I don't know, we probably all feel the same way, but we're pretty lucky to be training here. I feel like we see the bread and butter and then we see the more rare cases. So we're usually really good at diagnosing things. But in many centers who have limited limited exposure to these cases, the clinician or the surgeon may not have ever seen a patient with a necrotizing soft tissue infection. And there's been some strong data out of France suggesting that outcomes were better when the surgeon had experience treating the condition. And that's likely because we're better at detecting it and diagnosing it early, you know, as opposed to someone who's has never seen it or has never diagnosed it. So given its low incidence, many surgeons, many physicians will rarely encounter it. And if that does happen, they should be transferred to a center where there's expertise, surgical and medical expertise in treating these patients. Management should be multidisciplinary. That's the cornerstone. First thing you're going to do is resuscitate the patient, get microbiological samples. You're going to get blood cultures, skin cultures, and then you're going to start broad spectrum antibiotics, and we'll go over the antibiotics. Then you'll want to, you'll want to make sure that you have a multidisciplinary team. It's not just us, the surgeons, the anesthesiologists, usually infectious disease, maybe dermatology, wound care nurse, PTOT, admit them to the ICU if they have ICU level care. And then as soon as possible, take them for surgery if they're in sepsis or septic shock, or if they have overt signs of local signs of an NSTI. Post-op, they should be assessed by the multidisciplinary team daily, and they should be seen by a surgeon daily to assess for a relook surgery or second look surgery. See if they need to debride even more or not. You will get microbiological tissue samples once you take the patient for surgery, and you'll adjust your antibiotics based on that. Like we said, involve the wound care nurse, have adequate analgesia, make sure that the patient's tetanus vaccine status is up to date. And if they're not, they're going to need the booster. And then IVIG in cases of group A streptococcal, and we'll go over that. This is just another diagram to highlight the importance of management being multidisciplinary. I think it has pretty much everything that we talked about. All right, so antibiotics. So if you go through the data, there's no randomized controlled trials that were done to study empirical antimicrobial therapy in necrotizing soft tissue infections. The data is mostly derived from studies that were done in non-necrotizing skin and soft tissue infections or observational studies. Usually we'll start with a broad spectrum beta-lactam that has activity against gram positives, gram negatives, and anaerobes. So you'll put the patient on Zosyn. You can do a carbapenem. You can also do a third generation cephalosporin with the metronidazole, so like cefepime, flagyl. If the patient has high risk factors for MRSA, if they're IV drug users, or they have a port, or they're dialysis patients, or depending on the local risk factor, like the local microbiology and carrier states for MRSA within the community, you may consider anti-MRSA. You would want to add clindamycin if you're suspecting group A streptococcal infection, and that's to limit toxin production. Then you'll adjust your therapy once you've got the etiology identified and the susceptibility is obtained after you get tissue diagnosis, and duration of therapy is 7 to 10 days from the time that we get source control. Again, this is derived based on observational studies with no randomized control trials. Surgical management. Surgery is probably the most important thing, and the most important modifiable prognostic factor. Time to surgery is the most important thing. There's very strong data to suggest that mortality is worse if surgery is delayed for more than 14 hours after an ICU admission. There's one study actually that said 6 to 12 hours mortality and outcomes were worse. Cases who are uncertain, those should go to surgery. Those should not wait. Surgery doesn't only confirm the diagnosis and get samples, but also really manages the disease. You want to get complete debridement and removal of the necrotic tissue. You want the surgeon to see them every day. I mean, at least in the cases that I've had, almost always they go for a second surgery the next day or within the first 24 hours. And that's important because you want to make sure you've had enough source control, and necrosis usually progresses. So even though you think that you've debrided the entire area, necrosis can progress and you may need to go for another debridement and another debridement and another debridement. Once the wound is stable and you think you won't be going to the OR again, usually the surgeons apply negative pressure therapy or the wound vac. That helps with decreasing the surface area of the wound, clearing the cellular debris, and induces granulation tissue formation. What about IVIG? So IVIG has been proposed as an adjunct therapy for severe infectious diseases. It has immunomodulatory effects. It opsonizes bacteria and thought to neutralize bacterial toxins, but its clinical benefit in sepsis and NSTIs has not been proven yet. There's the INSTINCT trial that came out in April of 2017. It was a randomized blinded placebo-controlled trial. Was published in the Journal of Intensive Care Medicine. Randomized a total of 100 patients to with NSTIs in a 1-to-1 ratio to either receive IVIG or placebo, which was just normal saline, daily for the first 3 days during their ICU admission. The primary outcome I thought was interesting. They measured the physical components summary score. It's a 36-item short score at 6 months, and it basically looks into physical abilities and physical functioning. And they found that the group that got IVIG had no improvement in physical functioning or no apparent effect at 6 months. Then in 2018, we had a meta-analysis that came out. It came out in 2018 in Journal for Clinical Infectious Disease. Title was Intravenous Immunoglobulin and Clindamycin treated patients with streptococcal toxic shock syndrome. They looked at group A streptococcus toxic shock syndrome, patients who had gotten clindamycin for it and whether they did better if they also received IVIG. They did demonstrate a significant survival benefit. That's why we usually use it, or we recommend it for GAS toxic shock syndrome. Pooled data included 70 patients who got IVIG and 95 who did not get IVIG, all had streptococcal toxic shock syndrome. IVIG treatment was associated with a reduction in mortality from 33 to 15. Pretty significant. What about hyperbaric oxygen therapy? It's not part of the guidelines, not part of the recent IDSA guidelines. And the reason for that is because it's thought to be an adjunct therapy, but it has not been proven to improve outcomes. There's some conflicting data out there. The way it works is that it increases tissue oxygen tension, thought to be maybe also potentiates antibiotic therapy. There was a report, a cohort of 344 patients with NSTIs, 275 had hyperbaric therapy. The authors thought that was protective for their hospital mortality, but then there was another Cochrane review. The Cochrane review wanted to look at evidence of use of hyperbaric therapy as an adjunct in patients with NSTI. they didn't actually find any trials that met the inclusion criteria, so they couldn't make a comment. And for that reason, it's not part of the recommendations or the guidelines. This is, I think, my last slide. Outcomes are poor, just like we said, 20 to 30% mortality rate. It's been pretty steady over the past couple of decades. Autoimmune disease increases mortality rate. Not just mortality, morbidity is pretty significant. One report showed up to 6% amputation rate. And that brings me to my take-home messages. You know, like we talked about in the first slide or in the case scenario, these diseases are life-threatening. They have high mortality, they have high morbidity, they're disabling. They can be a diagnostic and therapeutic challenge for the clinician. It's a lot harder to diagnose them if you've never diagnosed them or you've never seen them. And the likelihood is if you practice somewhere remotely, you may not ever encounter them. Management relies on multidisciplinary team approach involving us, the surgeons, the anesthesiologists, ICU nurses, physiotherapists, ID, dermatology. Early recognition is the most important thing, and that should trigger broad spectrum antibiotics and aggressive surgical debridement. And that's pretty much it. I'm open for questions. Sorry, it was a very short presentation, but hopefully short and concise. I actually didn't look through that. I didn't actually go through that, but it's a very good question. Maybe I'll look into it and I'll let you know. Very good question. I'm not sure. I can look into it and let you know. Yes, it's a diagnostic factor. Yep. You don't see it, doesn't mean that it's not there. Yeah. Yep.
One thing for the recent surgery of the gas to be left over from.
That is true. If they've had recent instrumentation, it could affect their imaging modalities. Imaging findings, yeah.
The trial that you brought up.
IVIG,
Yeah, it was regarding IBIG. So.
This one?
we were talking about the PCS. They only look at the survivors.
yes, so the ones who had not survived got the lowest score possible, which was 0. And it still did not affect outcomes. Thank you, guys. Yeah. Yes. Yeah, I don't think that was adjusted based on comorbidities. 20 to 30%. Yeah. Underlying comorbidities. Yeah. More likely that the patients who are getting it have risk factors. So your population at baseline is probably pretty similar within their comorbidities, but I'm speaking not off of data. So, but this was unadjusted. Stop sharing or do I stop sharing? Yeah.